Well, good morning, everybody. Thanks for getting up. As a person who loves sleep, I wish I were, but I'm happy to be with you today. So I was looking for the pointer. Anybody know where that is by chance? I've got a battery. Thank you so much. Okay. Well, I threw away the tie. I'm more informal today. Now it's time to roll up our sleeves and get people better. So, in my entire career, I don't think I've ever given a talk on treatment pearls. We talk about it in the hallway mostly. But I'll do my best to try to tell you what I think. So, now remember this. So if this is the way I see the world, where are all the places we can make some kind of difference? We can at least know who has hypermobility syndrome and know what the implications are. We can watch out for the comorbid issues that are so common among patients with fibromyalgia, such as kneecap pain going up and down stairs. We call chondromalacia patellae. Treat that with patellar taping. We don't do surgery for that anymore. Pes planus, flat feet. Always have people walk with their feet and watch how they walk. We're trying to figure out issues like much about prolapse and palpitations and so forth. It's very important that we don't lump everything in and call everything fibromyalgia all the time. It's very important to tease apart what people have. I tell people that fibromyalgia has this remarkable effect to amplify sensations. So if you're sleep deprived, even not to the point of full fibromyalgia, you're just sleep deprived, and you stub your toe, it's going to hurt more than it would otherwise. So the other issue with fibromyalgia is it's always symmetrical. It's both sides, top to bottom. So you can't have fibromyalgia of your knee or of your shoulder. But fibromyalgia can amplify it to make it more significant. So I've worked with orthopedists for a long time and try to help them kind of work through understanding the intensity of pain is different and how broad the pain is for these other problems like rotator cuff tendonitis and so forth. It's going to be broader and more significant. But let's not confuse it as fibromyalgia. And then the whole focus of my life is trying to get people's autonomic nervous systems to be somewhere closer to normal so that the inhibitory forces in the hippocampus balance the excitatory forces in the brainstem. And trying to help people watch out for things that might turn it on. They all know about stresses. They all know about worrying about their child. They all know about financial issues and concerns and being mistreated by people in many ways. But they might not know about some of the medical ways that the autonomic nervous system turns on. You already know I'm very worried about the spinal cord as an autonomic arousal. Not that everybody needs surgery, that I can't have an autonomic arousal going on in my patient when they don't know what's going on and thinking it's a migraine. I also have to worry about untreated sleep apnea. And over the years, it's become quite apparent that the traditional risk factors for sleep apnea are completely useless. One thing I didn't share with you yesterday is when we finished the Mirapex study, those people who took Mirapex but didn't do very well, because not everybody does well, at the end of the study, they wanted to know what they should do now. And although this kind of information is never published in the paper, we pretty much got a sleep study on everybody. And most of them had sleep apnea. And I had screened the best I could with daytime sleepiness and different scoring and asked them questions and clearly missed some people. And then one woman who had a sleep study, she didn't have sleep apnea. I asked her, are you sure you didn't have any neck pain? Because you couldn't have that either going in the study. And she said, oh, I do have some neck problems, but I really wanted to be in the study. So we got a dynamic MRI on her, and it was so bad that she had surgery in 3 weeks. I mean, it was really bad, right under my nose. That's a bit of an atypical story, but there it is. The other issue is the autonomic dysregulation. You all know about how your stomach works and stomach acid, and how many people here might take, or at least your patients take proton pump inhibitors. So we work on that. We work on the vasomotor issues. We've got a lot of people who don't like those sweaty palms all the time. And we try to explain that this is an autonomic issue. We don't really have a good treatment for sweaty palms, but if we treat the brainstem, then we make progress on these autonomic features. And then I'm afraid I'm a bit of an outlier on psychiatry. I really think it's neurology mostly. It is interesting that the one psychiatric state that's associated with high dopamine levels, schizophrenia, almost is never seen with fibromyalgia. And Patrick Wood even has told me that he's never heard of anybody who takes care of fibromyalgia who's ever had a patient with schizophrenia, honest to goodness. I think I've got somebody with psychotic features with bipolar, but he's probably right. There's something there about their very high dopamine levels that cause those problems at the D2 receptor. So, but things like panic disorder and post-traumatic stress disorder and palpitations, unexplained chest pains, I really think there's a substantial autonomic component to these things. And then we do everything we can to get you your sleep back. I will tell you that my philosophical view on this comes from patients. And the patients who have recovered, that now there are patients, and there are patients who completely recovered. I just wish there were more. But the ones that do always say the same thing. They sleep like a 5-year-old. They fall asleep quickly, they sleep through the night, they wake up refreshed. And I really believe Moldavsky was right. This is a sleep disorder. But it's the autonomic disruption that leads to the sleep disorder. So if you sleep like a 5-year-old, your sympathetic nervous system is nice and quiet, just like that little kid in the back of the car. It's out. They're safe, they're lulled to sleep, and getting that back is the secret, probably, I think, to fibromyalgia. So basically what I try to do is identify every sympathetic arousal I can get my hands around, even the ones I didn't know were there, like the neck and sleep apnea. I think about dopamine agonists and restless leg medications because that's all we have that treats at least the autonomic nervous system so far. That's safe. I'm afraid Marilyn Monroe did find something that treats the autonomic nervous system, sleeping pills and high-dose Valium, but that's not a practical treatment for fibromyalgia. We worry about the sleep apnea and the cord compression that needs to be figured out. When I do a consultation, I don't start people on dopamine agonists. That surprises a lot of people for the person who designed the study. But I say, no, I don't. And that's why I encourage everyone who treats fibromyalgia who's even considering that type of strategy based on the results of the study to read the paper, because the details in there are the exclusion criteria. And I would say that only about 25% of patients who see me would qualify for that paper because only people without sleep apnea and without cord compression, I believe, have fibromyalgia in really more of a truer sense. We screen for sleep apnea in everybody. We don't tell the patients you need to screen for sleep apnea because the people who will say, I won't do that CPAP no matter what, so I won't get the study, which I don't blame them. Or they'll say, there is no way I have sleep apnea. I don't even snore. Well, it doesn't matter. So what we tell people is we're getting a sleep study to look at stage 4 sleep deprivation. We're measuring cortical arousal. We're measuring the problem. It's like if you have leukemia, we get a blood test. You have fibromyalgia, we get a sleep study. But unfortunately, all sleep studies aren't the same. So it's taken me years to figure out in Seattle who's got the quality sleep studies. And so that is a challenge. And some patients have had 2 sleep studies because the first one I just didn't trust. It didn't make sense. We're developing questions that may screen for who needs a dynamic MRI. We don't want to necessarily get an MRI on everybody. Although with this data, if it really is anywhere close to 2/3 of patients, then maybe we just shouldn't be missing it. We can certainly spend as much money on it that it costs to get an MRI on drugs and office visits very quickly. So it may be cost effective to check that MRI quicker than we thought. It is difficult to persuade those local radiologists to do these 2 extra views because it takes them about 15 minutes, and that time is money on that MRI. And they won't get paid for that. And they don't want to measure all these measurements because it's a pain. But once they do it and help people and you engage them and tell them that they're making a difference, sometimes they will. And then, of course, if they get a lot more business, they're happy about that too. We will usually start someone, when I see them, if I hear the story of fibromyalgia, and I'm pretty convinced and I'm suspicious that they may have a cord compression issue too, which is very common. We'll start them on low doses of lorazepam and clonazepam. Now these are doses that are in the textbook. They've been around forever, 40 years. And both of them are used for restless leg syndrome, and we use those doses. So what I'll do is I'll be very conservative in terms of starting and cautious, because I've got sensitive people I take care of. And I'll start with an inadequate dose on purpose, and I tell them this. I start with 0.5 milligram of lorazepam, then 1 milligram, then 1.5, then 2. 4 nights, that's it. 10 pills, that's all they get. Then they get another prescription of clonazepam, same story. Half, 1, 1/2, 2, 10 pills. Then we say, call me back in 8 days, let me know what happened. Tell me which one worked the best and at what dose. And I say, don't increase the dose if you're having any morning grogginess. I mean, be sensible. And they're usually already on some type of sedating nighttime treatment already, and I say, combine it with your trazodone, with your muscle relaxant, with whatever at night. It's okay, we're going up very slowly. But if you notice morning somnolence, don't blame the new medicine I gave you. Lower the other medicine, the Ambien, the Lunesta, the trazodone, amitriptyline. Lower that one, because as you control arousal, you need less to induce sleep. Which brings me to an important concept. I don't think of sleep as sleep. I think of sleep as 2 parts. You're lying in bed, you can't sleep. There's a dog barking outside. That's an arousal. That's an autonomic arousal. No different than smoke or baby crying or anything else. If you get rid of the arousal, you might sleep. Unfortunately, if you get rid of the arousal, you still might not sleep. So the Ativan, the lorazepam, clonazepam treat the arousal in the brainstem, the autonomic arousal. Okay? They're lousy sleeping pills. They're not for insomnia. They're for people with excessive arousal. And that's very important because they're generic. They're not FDA approved for sleep, although temazepam has been, which is related, but which, by the way, doesn't work as well. But you know everything we use is off-label, so that's already been said ad nauseum. But in terms of a strategy, this strategy seems to be helpful, and it gives patients most of the time some confidence to get their foot in the door. They feel like, okay, something's going to do a little something. And sometimes they do quite a bit. This is the slide you already have in the study, and shows the different medications that are available. None of them are FDA approved. A pregabalin study was just reported 3 days ago. 725 patients. This is the phase 3. Unfortunately, the data was no better than this. It was 30%. They used a 600 milligram arm, and their placebo arm was 15%. So it was actually a little worse. But they're probably going to get FDA approval. So right now we do use it, but we tend to use the pregabalins and the anti-epileptics more for the people with the cord compression. Again, you don't know who they are unless you check. Duloxetine may also have more of an effect on cord compression. We know it treats neuropathic pain. It doesn't treat the limbic system or the dopamine axis at all. Pramipexole, as I've already told you, very, very good for the limbic system, autonomic regulation, the whole gamut, but lousy for the spinal cord. And sleep apnea will completely block its effect. So again, in the paper. This is something I added last night. This is published at the bottom. You'll see here, you might want to write this down. Journal of Rheumatology, 2003. This is a letter to the editor talking about some of the early findings in pramipexole, and this you might find instructive. We suggested 89 patients start this pramipexole protocol that's in the placebo-controlled trial, that same thing. And we talked to them about nausea, and we used high doses of proton pump inhibitors. This is half the FDA-approved dose, so this is not a toxic dose, but it's 3 times what you'd expect. We pretty much give them the 4 different branded proton pump inhibitors. We give them samples. We don't give a prescription. And a little piece of paper that says take 3 of one the first night, 3 of another, 3 of another, 3 of another. So it's only 4 nights. After that, you do whatever you want. We do it because of this data. 75 patients actually took the drug, because not everybody does what you tell them, and 56 had nausea. Now you say, well, why would you use a drug that causes nausea in 56% of patients? Well, what we did is we were working on strategy. They didn't have nausea if they did what we told them here. Basically, we told them to take the PPIs this way. Unfortunately, 16 of 75 stopped the pramipexole due to nausea, but here's why. 8 of them never took the PPI. They said, well, I don't want to take a lot of extra drugs. I'll just try the pramipexole. Well, bad idea. Very bad idea. The low dose, they took too low because the pharmacist says, oh, you only need 1 of those. People only need 1 Nexium, not 3. Bad idea. This is a hyperadrenergic state. The brainstem is very powerful, drives to the vagus nerve, hyperacidity. And then 2 of them took the correct dose and they still had nausea. So at the end of the day, 3% of the people who took the pramipexole couldn't take it due to nausea if they just followed the instructions with the PPIs. So those PPIs are just as important. And what was interesting about this is that the success rate for the different PPIs didn't make any sense at all. Pardon me for using the brand names here because I didn't have a chance to change it, but this is the success rate according to the patients. Did the drug stop the nausea they had? And I'm not endorsing this drug over this drug because I don't know if it makes any sense. But the point here is you got to try them all because some people would like one but not like any of the others. And that, I don't have an explanation for that. But it's very important to give them all 4. And what's interesting is after 2 months, this is a 3-month escalation of the pramipexole, but after 2 months, only 15% of people were taking the proton pump inhibitors, and that's the same number of people who walked in the door taking them when we started the whole thing. So they take it for 3 to 6 weeks generally, and then they don't need it anymore. It's the low doses of a dopamine agonist that are trouble, not the high doses. Remember this thing. Just to remind you, I can't overemphasize this enough. This is not something where everybody's going to need surgery. Only 10% of people have had surgery. 90% are being treated with a myelopathy physical therapy program, which, by the way, can be quite successful. It is not regular physical therapy. But unfortunately, the therapist who does it doesn't really have it written down how to do it. But all that's in the works. So basically, for the myelopathy patients, we're looking at diameters of 0.65 to 1 centimeter. These are the folks that generally we treat medically, not surgically. There are people who narrow below that, which is less than 50% the diameter of your spinal canal. Now, what's amazing about this is that they're walking around, and they're all around us all the time. They're miserable, but they don't have major neurologic loss. They just have misery and pain and autonomic dysregulation and features that look like fibromyalgia. Because they intermittently compress the cord, they don't do it all the time. They don't become quadriplegic, but they seem to go on for decades, and the insulting injury is usually 20 to 30 years ago. So we use the clonazepam and lorazepam, which is also not just for restless leg, not just for autonomic arousal. Both drugs are used in spinal cord injury patients. That was made apparent to me at a neurology meeting in December. I had no idea. I don't take care of patients like Christopher Reeves. I had no idea they were using these drugs. But that is interesting. Crisaprotol is a muscle relaxant that you can combine often with clonazepam. And of the muscle relaxants, it's sort of the forgotten one, and it's the hated one. It's forgotten because it's old and nobody makes money off it anymore. And it's hated because they think it's addictive. Here's the story. It's metabolized to a benzodiazepine, which is what makes everybody worry. But the benzodiazepine probably treats spinal cord irritation too. So we let them take up to 4 a day. And it's sedating like any muscle relaxant. 1/2 to 1 twice a day as needed, and 1 to 2 at bedtime for sleep, because guess what? Muscle relaxants help to induce stage 4 sleep a little bit. Okay? So sometimes you can work the sleep angle and work the spinal cord and the muscle at the same time. You're always going after the cause of the muscle spasm, but still, that's how you do it. The next one is tizanidine. It's very interesting, and tizanidine also affects the alpha-2 receptor, which affects autonomic arousal. I don't know if you picked it up, but very briefly there were some comments on the alpha-2 receptor in the brain. Again, it's used for spasmodic muscle issues. Analgesics, these are the people who need chronic narcotics. These are the people who suffer more than fibromyalgia alone. And these are the people who are generally disabled. Physiatry, I'm a big fan of physiatry, but for some reason our physiatrists have this terrible mental block about anything. Any diagnosis starts with the letter F. I don't know what it is. They hear fibromyalgia and their brain stops working. And I only have one who will even listen, and that's very sad because we need the physiatrist to help us with this spinal cord dynamic issue. And the chiropractors have been invaluable as well, but sometimes there's only so much they can do. But I say don't be manipulated unless you show your chiropractor the MRI. Give them a heads up on what's going on with your spinal cord. And then finally, the surgical issue. We've had 120 out of 1,400 patients. The other 1,300, they're not going to have surgery. They're never going to have surgery. They're treated differently. This is just an autonomic arousal issue where the cord has relevance. But for the 120 who've had surgery, there's an ongoing database, and the stories of improvement with surgery are real. They are. And this is not hype, I'm just telling you. Of those poor, unfortunate patients that we've seen, 50% literally don't have fibromyalgia when they're done. 50% still do. And they come back and they still have all the tender points, but their neck's a lot better. They're lousy sleepers, and now we treat them like they have fibromyalgia. and they usually respond to the pramipexols and the things we do, because we've gotten rid of this very major spinal cord irritation. They still got to treat the sleep apnea and everything else, but it is those people who are explaining what this really is, because they can tell you that their claustrophobia is better, their palpitations are better, their pedal edema is better, remarkably better, their puffiness is gone. There's a lot of features that we attribute to fibromyalgia that really isn't. So anyway, you're going to get even more on the different drugs from Cindy, but I want to at least tell you my very biased view and what I do in the office. Thanks very much.